morning. I'm Kelly Morris, Vice President of Individual Giving at Phoenix Children's. Thank you for joining us for our first ever virtual Within Reach speaker series. I would like to introduce our moderator for today's discussion, Randall McNeill. Rachel is a morning anchor for Today and AZ on 12 News. She has 25 years experience as an Emmy award-winning news anchor, most recently at NBC Houston. Rachel is also a part of our Phoenix Children's family, having moved to Phoenix in January 2019 when her husband, Dr. Wayne Franklin, was recruited as co-director of our Heart Center. In Rachel's other full-time jobs, she is a mom of 2 boys, Lionel and Hudson. In her free time, Rachel enjoys traveling back to her home country of Jamaica and exploring Arizona's trails and restaurants. I know you join me in giving a warm welcome to Rachel McNeill.
Thank you guys. Welcome. Hope everybody's staying healthy and well. I really appreciate you having me here today. So before we begin, just a few housekeeping notes to let you know about before we start the webinar. We're going to come back on some of the feedback noise. So we're going to go ahead and mute everybody because I know we're having the aquarium sound. So we're going to mute everyone. But if you do have a comment or you want to do a question, we'd love to get the questions in. Please type it into the chat box located at the bottom right of your screen, and then we'll get to your questions. So today's Within Reach speaker series will be highlighting how Phoenix Children's multidisciplinary team specializes in treating and caring for children with chronic medical conditions with early identification and intervention practices to prevent serious mental issues. Now, joining us in this webinar today to discuss the mental health management of pediatric patients with multiple diagnoses are Dr. Randall Ricardi and Dr. Emma Ross. So we thank both of you for being here. Dr. Randall Ricardi is the Division Chief of Psychiatry at Phoenix Children's. Dr. Ricardi is a child and adolescent psychiatry specialist here in Phoenix and has been practicing for 31 years. Dr. Emma Ross is a staff psychologist at Phoenix Children's Hospital who performs inpatient consultation and liaison services for the inpatient medical floor. She is also the dedicated psychologist on the palliative medicine team. She did both her internship and fellowship at Barrow Neurological Institute at Phoenix Children's Hospital. So thank you, Dr. Ricardi and Dr. Ross, for being here. We so appreciate it.
Thank you.
All right, so to start things off, as a premier children's hospital, Phoenix Children's physicians and staff, they see a wide variety of diagnoses. These chronic conditions are often intertwined, which is why a multidisciplinary team is necessary to treat not only the patient, but their families as well. Can you tell us a bit about adverse childhood experiences and why it's so traumatic? Dr. Ricardi, we're going to go ahead and have you kick things off for us.
Sure. Yeah, thanks. And thanks for hosting today. And thanks to everybody who's taking time out of their day to join us and learn more about Children's Hospital and psychiatry and psychology services here. Adverse childhood experiences are interesting in the sense that we're learning a lot about the impact of stress, trauma on the developing brain. Even during pregnancy in utero, stress impacts that developing brain. And as a result of stress, we see that it can result in mental health issues as well as complicating medical outcomes. And so we've been able to associate adverse childhood experiences with such things as the development of ADHD, of learning disabilities, of other anxiety disorders, as well as other health issues. So one of the things that we are having a better appreciation about is that the stress that patients and families go through will vary from patient to patient, where one patient may come through a process without any problems, unscathed. Another patient and family may come through and really demonstrate, because of that stress or trauma that happened, changes, and that impacts then what happens to them downstream. And I know Dr. Ross is going to talk about that in a little bit more detail. But for example, we've seen kids who come down for chemotherapy, for example, and you'll often see as a result of chemotherapy, nausea and vomiting. The brain actually, for some of these kids, just driving down to the hospital, we'll see that they start to get nauseated and will start vomiting even before they have the procedure done. And so the brain is extremely sensitive and can be shaped by some of these experiences. So we are paying attention more to some of these traumas that happen, even small traumas, and the resulting impact. What do you think, Dr. Ross, about your experience with adverse events?
I mean, I think back on what you said, that for a long time we thought of adverse childhood experiences as being what we would think of as major traumas, like maltreatment or witnessing violence or enduring a natural disaster. But what we now know from a good amount of research in clinical practice is that any experience that is perceived as distressing and potentially traumatic during childhood that goes on to have negative consequences across numerous functional domains in adulthood, we would consider an ACE, or an adverse childhood experience. And so within this broader umbrella, there's a lot of aspects of healthcare and diagnosis and treatment that are pertinent. I think that a really good example that hits on sort of what you were saying, that adverse experiences are multifactorial, would be bone marrow transplant. So for this type of intervention, after diagnosis, which in and of itself is traumatic and distressing, appropriately so, a patient's admitted for a month, oftentimes longer. Unfortunately, many will undergo side effects that land them in the ICU. And then once they finally are discharged, they're having to come back to clinic several times a week for up to a year. And that family has to live within 30 miles of the hospital for up to a year. So for a lot of our families, the distressing nature of transplant is one thing, but being separated from your family, having to be in a new environment, having to switch floors during hospitalization, these are all equally stressful, though not typically considered ACEs. And I think in particular, we also have to be mindful of a lot of social and environmental stressors that go along with hospitalization. It's not just all about the medical treatment. So I think when I think of a patient that really exemplifies struggles and adversity and just a multitude of potentially traumatic events, I think of a patient named Ray, who was 2.5 when he was diagnosed with a form of ALL. And unfortunately, this young man relapsed not once, not twice, but 3 times. And the type of leukemia that he had was so aggressive that he needed to undergo a type of immunotherapy called CAR-T, then followed by transplant. So this young man was in the hospital with his mom for months. Unfortunately, part of that was in the ICU over his 10th birthday. But when we really look at Ray, what I find so interesting, what oftentimes gets missed, is that Ray's first language was not English. Most of his family lived in Mexico, and the social support that a lot of our patients have, his family did not have that luxury, at least not face-to-face. So in addition to all of the stressors we've talked about with transplant, inherently that's difficult, he also had the stressors of a different environment and different social supports to back him up. And I think that this is a true testament to what Dr. Ricardi was saying, in that kids respond differently. So for what may have been really adverse traumatizing experiences for him may not have been as traumatizing for others. But he did require almost daily sessions with psychology. Dr. Ricardi did beautiful medication management with his team. And as a group, cohesive effort, we were able to better equip him with the skills and the tools that he needed to adjust to his situation. So I tie up that story. Ray's doing great today. He's been in remission over a year. He's thriving. He's healthy. He's looking forward to going back to school in the fall if schools reopen. So this is not to say that when kids experience adverse experiences, they can't go on to be resilient and successful. They absolutely can. But we do have to conceptualize adverse experiences as so much more in depth and so much greater than just the medical diagnosis itself.
Exactly. And I think as we appreciate that more, one of the things that we're learning is that even in pregnancy, the stress that something could happen during the pregnancy to the mom, that results then in changes because of that whole cortisol system to the developing brain. And so as a result, we're starting to do things at Children's with perinatal and infant psychiatry, moving in a different direction of saying, if we anticipate adverse issues that really do impact that pregnancy, and then downstream effects like Ptsd or ADHD, can we do things preventatively rather than waiting for something to happen and then beginning to initiate treatment at that point?
And Dr. Ricardi, I know it's so overwhelming. I can only imagine for families to learn that their child has a congenital issue. Can you explain how important the mental health component is for a family, that it reaches beyond just understanding that initial diagnosis?
Yeah, I mean, I think if you really then take what we've talked about with ACEs and the adverse events, and then you think, here we are delivering news, child's going to have an issue that could be lifelong and chronic, a congenital issue. There's more than just the medical piece to this. So I remember sitting in on a case where the medical team was delivering news to the family about a congenital issue that was really going to impact that child for the rest of his life. And the dad, when they asked the family, do you have any questions? The dad said, will we be able to hold the child after it's born? And I thought, you know, that tugged at just your heartstrings of saying, you know what, it's more than just the medical care that we deliver. It's also that human part of what we're all about and what we do in our delivery of care day to day. And I think the mental health team brings that to the overall multidisciplinary teams so that we are providing integrated, collaborative kinds of care for our families that we take care of. So when somebody is dealing with all these complex medical issues, I think we also have to appreciate, as Dr. Ross has talked about, is that families are juggling other responsibilities. They're juggling other family members at home and jobs and having to put food on the table. And so when you start to step back and put yourself in their shoes, you have a better appreciation how as a team we really think about this in a more conceptual way.
So Dr. Ross, 99% of the services that you provide are inpatient, dealing with patients in the pediatric intensive care unit, cardiovascular intensive care unit, and those waiting for bone marrow transplants, as you talked about, those with terminal diagnoses approaching end of life. Can you talk about your efforts to try to mitigate the rates of PTSD in children and provide some resources to try to boost resilience in their parents?
Yeah, so PTSD is so fascinating, at least to me, because historically its roots are in military veterans. So it has taken quite some time for the clinical and research community to acknowledge that kids not only can, but often will go on to develop symptoms of PTSD following a traumatic experience. And when I say symptoms of PTSD, there's a lot that we use to diagnose, but the big three, or the core three, if anyone's heard of that before, are re-experiencing, avoidance, and hyperarousal. So re-experiencing is what people are referring to when they're saying they have a flashback of the traumatic event, they're having distressing dreams of what happened. In kids, we're seeing this a lot more through play, which makes sense developmentally. Hyperarousal is just you're jumpier, you're more on edge, your startle reflex is heightened. And then avoidance, so trying to consciously and unconsciously avoid stimuli or things that can remind you of the traumatic event to avoid distress, but also the rest of the symptoms that come along with PTSD. So we have gotten better in the research world of understanding the development of PTSD following certain types of trauma. But one area that we don't understand all that well right now is the development of PTSD symptoms following medical trauma. Within this category, we know even less about the development of PTSD following medical trauma in kids, and even less so when the medical trauma is more chronic, long-term, or not one specific acute event. So again, since we've already talked about transplant, I'll use this as an example. What Dr. Ricardi was referencing as far as kids having to come back to the hospital for clinic visits for up to a year after they've been discharged. Most of us, if we experience a trauma, we can just not go back to that place to try to avoid feeling distressed. So this is not an option for a lot of our patients. They are constantly being surrounded by triggers, and not just them, but their parents as well. And kids are sponges, and they model what their parents do, and they often reflect thoughts that their parents say. So if a parent's at increased risk for PTSD, we can assume that that child is also at increased risk. So one of the initiatives that myself and the palliative team and the bone marrow transplant team are really trying to take efforts to do is to better understand the development of PTSD symptoms among our BMT population, as well as their caregivers. And not just the rates, so what percentage of people get it, but what are the trends in symptom development? And we would do this by administering screeners, so looking at different symptoms of PTSD at fixed time points, so on the day of transplant, and then at 3 months, 6 months, 9 months, all the way up to a year. So we would not just be assessing them at the time of the trauma, we would continue to provide assessment and support 1 year post-transplant. And ultimately, the goal of this is, one, we can better detect when symptoms are present, so we can intervene faster. We can get psychology and psychiatry to meet these families and patients more proactively. But the larger goal is that we would like to be able to take a preventative approach to the treatment of PTSD. If we know which kids and we know which caregivers are at greater risk for developing symptoms even before they come to transplant, well, that would be spectacular. We could get them involved with mental health services before the process even starts, increase resiliency, reduce anxiety, and help them better adjust to the transplant process, and then ultimately improve outcomes in terms of mental health across their journey.
I think one thing that you talk about as well is provider fatigue, and that's something I feel like we're seeing even now with COVID headlines.
Oh yeah, PCH has been sort of at the forefront, I feel like, of being interested in provider and physician and staff wellness, but especially in light of COVID-19, there's even more efforts being directed to look out for our staff and the people who work here. When we say provider burnout, many times people think of this as just being tired, but it is actually a lot more significant than that. Burnout is associated with a general loss of interest and energy across all areas of life, not just professional. Disruptions in sleep, disruptions in appetite. We see higher rates of substance use, mental illness, physical ailments, and ultimately we see higher rates of turnover or termination. So there's pretty significant consequences, not just on the individual, but on the individual's family and on the institution as a whole. So PCH, I think, is sort of leading the way in physician and provider wellness. We have an amazing wellness center that's dedicated just to staff. Any person who's employed at PCH can go to the wellness center and get a variety of resources and tools to help with self-care, help with resiliency, help reduce anxiety. Unit managers can request workshops and seminars and trainings that are then brought to their unit. And it's really this wonderful resource that we have. But myself and several other groups in the hospital are really interested in taking a more proactive approach to reducing burnout. So rather than wait for the staff member to come right before they're about to quit and say, I just am exhausted and trying to get services, or a unit manager saying, for the past month or so, morale's been pretty low, and then seeking out a seminar. What we are striving to do is to better understand who's at greatest risk for developing burnout. Is it personality traits? Is it characteristics? Is it the types of patients that you're working with? Is it the management style of the unit? We have all these questions. So we would like to better understand across the whole hospital and all different staffing groups, not just physicians, everyone who's employed here, who is at greatest risk for burnout. So we can implement the resources that we have through the Wellness Center on a much more proactive basis and better target the services that they offer to the needs of our staff.
It definitely makes sense. Dr. Ricardi, as many of us have seen during the COVID-19 pandemic, the use of telemedicine has really taken off out of necessity. So what do you think the role of telemedicine will be in your specialty moving forward, and what other innovations would you really like to see on the horizon?
Yeah, so in psychiatry, telemedicine has been used in more remote areas where people have not had access to psychiatry. And because of COVID-19, it's been difficult for institutions across the country to safely bring patients to their centers, including at Children's. So as a result, we quickly had to mobilize and put telemedicine into place. And that was done, I would say, in neck-breaking speed. I was amazed at how quickly we were able to get that up and operating and do it in a rather consistent way. It's actually gone pretty well. And the feedback from families has been that they find it easier than having to previously take their children out of school, miss work, and that we've actually seen that our ease with being able to get people in much faster as well. one of the things that I anticipate is that because it's been so successful and that we've been able to see even more patients this way, that it will actually improve access to care. So when we get over this crisis and kind of go back to life as normal and patients come back to campus in a more regular way, I anticipate that we will see people in some of the outlying areas who previously had to drive hours in order to come to the hospital and receive care, that we'll be able to continue to maybe deliver that care to them through this mechanism. I think that will be a huge burden release for some of these families who missed all day of work and kids missed all day of school. The other thing that I think it's allowed us to do is be able to kind of integrate in more interesting ways. So I participate in a Tourette's clinic in which neurology, psychology, psychiatry would see patients in real time. And because of the crisis, we've not been able to bring the families and kids down to the hospital. So we've been able to actually do multidisciplinary clinics through telemedicine where we all meet together. And it's actually gone rather smoothly. And I anticipate that for those families who have to travel long distances, that we'll continue to do multidisciplinary clinics that way. The other thing that we did was we initiated through kind of the tele-platform like we're doing today. We're having kind of an education series. Well, Psychiatry did a podcast series in which we talked about parenting during the pandemic. And it was actually well received. And one of the staff members sent us a note afterwards and said that they both laughed at some of the examples we gave about, you know, you do the best you can, and sometimes you make chicken McNuggets that look like dinosaurs for your child. And they said they also cried because they realized that they were not alone through all of the challenges that we're facing. I think that one of the things that I would like to do as a new innovation would be to have an ongoing podcast series in which we talk about the challenges that families go through in dealing with chronic illness and mental health issues. And so that would be something that I see this platform changing as we move forward as well. And some of the other things that when you talk about new innovations, we're going to maybe move into the direction of saying, what do we do to help kids not who are responding to therapy, who are not responding to medication? What do we do to help them? And I could see that this will open up avenues for doing things like transmagnetic stimulation, which is a non-invasive treatment in which we send a magnetic pulse to certain areas of the brain to help with specific anxiety disorders or depression. And we may at some point even look at infusion programs for ketamine for individuals who have severe suicidal ideation and behaviors that otherwise are not responding to traditional treatments. So that's how I kind of see how telemedicine is going to change what we're doing currently and what we're going to do in the future, and maybe some new innovative things that are going to be coming down the road.
So in that vein, though, this question is really for both of you. What's one of the greatest challenges or maybe hurdles that you see in your specialty right now that you're passionate about changing and improving? We're going to start off with Dr. Ross first.
I mean, I feel very fortunate that I am a psychologist during this time. Every single year, some of the stigma of mental illness gets chipped away. People are more open to getting services. The society as a whole seems to be moving the direction of commending people who go and seek treatment. So I do feel fortunate that I'm part of this shift movement as a culture where we see healthcare as not just physical or medical health, but also good quality mental health. I think as a testament to this, at PCH, psychology is busier than ever. I don't know if everyone knows this, but for any patient who's admitted to PCH main hospital, anyone can get access to psychology. So a family can request a consultation, or the team can notice perhaps there's some mood or behavioral concerns and request psychology involvement. And what this means is that we go in, we provide an initial assessment. We staff the case with the team. Most of the time, we'll continue to follow the patient all the way throughout their admission until they discharge to provide evidence-based interventions to help them cope or navigate the surroundings more effectively. And then at the time of discharge, we provide disposition recommendations. So what do they need in the community to continue to thrive? So we are full-time in the hospital. We have a vibrant outpatient psychology clinic that sees patients and families from the community. And we also, like Dr. Ricardi said, are embedded in several different multidisciplinary clinics. So for our division, our clinical practice is at an all-time high. When I think about challenges, I think one of the major challenges that our specialty faces right now is finding a more delicate balance between pursuing good clinical work as well as good research. So evidence-based practice is only as good as the research that's behind it. And if we don't constantly have new studies being done and trying to obtain as much data as possible from reputable sources, then we can't be sure that what we're doing is effective. And that's all of our goal, is to give effective interventions. So because our time has been so focused on expanding the clinical role and meeting the clinical needs of our patients in the hospital, a challenge has been finding the time to be able to work on our research projects. But it's not just time. Another issue, and this is not a PCH issue or challenge, is that funding for mental health or behavioral health projects is just not the same as other types of research. I don't understand why. I think behavioral health is just as jazzy and exciting as other types of research, but for some reason, funding agencies just don't find studies like looking at rates of PTSD among BMT patients and their caregiver, or trying to reduce provider burnout. This just isn't as jazzy as drug trials. So historically, and still in present day, it is challenging to get the funding that we need to do these longer term studies, but those are the types of research and projects that really give back to the research base that then help us develop new types of interventions. But I am passionate. I work with an incredibly dedicated and passionate team as well, of trying to balance the scales a little bit more over the next few years of research and practice, both so we can give back to the research base and advance our interventions that we give, but also to highlight the amazing patients, the wonderful families, and some of the really innovative programs that we have going on here in the hospital at both the state and a national level.
Dr. Ricardi?
And I think for psychiatry, some of our challenges are that the workforce currently for child psychiatrists in this country, almost half of us are approaching the age of retirement. And we're not seeing coming up through the ranks enough replacement child psychiatrists to meet the growing needs and demands in our state and in the country. So one of the things that Children's has done is that we've started a child fellowship program in which we're training new child psychiatrists, hopefully to stay at Children's and within the state, or moving someplace else in the country to meet some of this growing demand. But even with that, there's such a shortage of providers, and the wait time to see a child psychiatrist is so long that one of the other things that we've started to do is start faculty learning communities. And in that faculty learning community, what we decided to do was to invite community pediatricians. So our first one that's currently underway, we've invited 10 pediatricians from the community from varying practices to begin to learn about managing, diagnosing ADHD, depression, and anxiety, with the goal of increasing their comfort level in just treating and diagnosing mental health issues. Because we recognize that these families have nowhere to go. And so they're going back to their primary care providers saying, please help us. So we are providing a 10-month course to pediatricians, and we're actually getting ready to start a second FLC to expand it to maybe 15 different providers this time. And with that, we hope that we'll see more providers stepping up, being comfortable with managing mental health issues. The second thing that we've done at Children's is we've started a bridge clinic, and we've used some of the psychiatrists to see patients in the short term to be able to kind of like assess, stabilize, and bridge them until they can either see a psychiatrist in the community, wait time sometimes up to 3 to 4 months to see somebody for a new appointment, or to go back to the pediatrician. Our thought with the faculty learning community was, let's put a bridge clinic around these pediatricians to begin to support them when they're having challenges with the patients that they're now treating. Can we see them with them stable and keep them in those pediatric practices? So as we talked about new innovations and what can we do with telemedicine, one of the things that we're now going to begin doing is using telemedicine to maybe integrate with these pediatric practices. So how nice would it be for families during a pediatric visit for us to just zoom in, do a telemedicine visit with them in the pediatric office and begin to like reinforce concepts, teach, support the pediatrician and families and work together in a team, even with our community pediatricians. So that's another one of our challenges of how do we begin to get more access to care for some of these families that we're seeing.
And Dr. Ricardi, is there an area of focus in your program where you really like to see that philanthropy could make a huge difference?
I think there's several opportunities, and as Dr. Ross talked about, for individuals who want to step up and to participate in the further development, in understanding research, but also in treatment. As we talked about, it would be nice for those kids who have not responded to traditional therapy or medication, if we had the ability to do transmagnetic stimulation with a non-invasive machine that would help them get through bouts of depression or anxiety that otherwise was not responding. That would be a tremendous opportunity, I think, for someone to help both the institution, but also help the community and for the families that we serve. I think that from a preventative standpoint, having people appreciate the role of perinatal and infant psychiatry and maybe learn more about that and expanding clinic and service areas to new families, those dealing with congenital issues, but just even dealing with pregnancy and the risk that we know with postpartum depression and psychosis and that downstream effect. There's opportunities there as we expand programs. The one thing that we haven't talked about that we often hear neglected are fathers. I mean, the dads are often involved in the care, and yet you don't see many programs that talk about fathers' involvement in clinic care and what they go through during high-risk pregnancies. So I think there's a lot of opportunities if somebody wanted to step up and say, you know, that really speaks to me, or that kind of tugs at a need, that there's so many different options for them to be able to reach out and help us.
Dr. Ross?
Yeah, I think, you know, similar to what Dr. Ricardi said, there are pockets that we are starting to dip our toes into, but we don't really have comprehensive programs for yet. But what we know, especially from the perinatal and prenatal standpoint, is that a lot of these parents already have kids, which means that this unborn child has a sibling. And from what we know in the research about child development, that if parents are struggling, mothers and fathers, it's a high probability that that sibling or other people within that home are going to be struggling as well. So I think having more opportunities to provide sibling support, whether that's through groups or telehealth, but program development where we're acknowledging the health needs of the individual patient actually expands to much more individuals in that family structure outside the patient themselves. So whether it's support groups with parents or with siblings, or retreats or workshops, I think there's a lot of areas that both psychology and psychiatry can more integrate within the family unit, still taking care of the patient themselves, but acknowledging the impact of an adverse health experience on a patient, on everyone in that community around them.
Dr. Ricardi and Dr. Ross, it's such good information. We so appreciate it. We're gonna open things up for questions now, and we're waiting to get some questions. I'm going to ask a question just personally, since I have the two experts in the Zoom room. Any advice for parenting during a pandemic? I mean, today is officially my kid's last day of school. I've got a 3-month-long summer that I got to entertain them now.
You want to go first, Dr. Ross?
Sure. I think, so first of all, there's some amazing resources on PCH website about parenting. So you don't have to take notes. If you want additional ideas, go to PCH for you, go to our website, Dr. Funda Vicini, Dr. Ricardi, a lot of the psychiatrists on our team have put out some really fantastic resources. So you're not just hanging by yourself. But I think there are a few things that can be helpful to remember. One, no one is supposed to know what to do. There's no manual for this as far as taking care of your kids in a pandemic. This is new for everyone, and to cut yourself a little bit of slack. Just getting through the day someday is doing a job well done. The other is to validate for your child that this stinks. Like, you're missing out on stuff too. It's okay to acknowledge that you wish you could go to your friend's birthday party the same way that they wish that they could go swimming. Kids take their cues from how you act, and if you pretend that everything's fine, that's going to be really confusing for your child. So it's okay to not be perfect and acknowledge that this is tough for them as well. I think the other side of that, though, is to limit unnecessary media exposure. Kids are thinking about this all the time anyway. Through social media, they're getting it. When they talk to their friends, they're getting it. When they miss out on an event they wanted to go to, they're thinking about it. So to turn the news off, turn the radio off, and to try to do that yourself in a private setting. Of course, you want to stay educated, but that's not always the best thing for kids. And then the last thing is to try as much as you can to keep a routine. Kids say that they hate schedules, that they want to do their own thing, especially since it's summer, all the rules should go out the window. But what we actually know developmentally from tons of research is that kids really like structure. Control, it gives them a sense of control, it gives them a sense of mastery of their environment. So if you always did bath and shower time after family dinner, try to do bath and shower time after family dinner. Keep as much of the routine consistent as you possibly can.
I'm going to record your answer because they want a later bedtime.
You're like, no.
Ross says no.
I mean, and I think as you talk about telemedicine, I mean, there's opportunities for you to be able to use the teleplatform for things. Like, I've seen families now have scheduled get-togethers across the country where they normally would not have been in touch with each other. They get together and they have like play dates, even like virtually, with their children. The other thing when Dr. Ross was saying about you may have to cut yourself a little bit of slack is that everything kind of gets presented with the same intensity and need, like it has to be done, it has to be done. And I've encouraged parents to really go through and say, especially with schools, is this really critical? Does it have to be done right now? Is this something that can wait and we can get through this crisis and we pick it up on in the fall? And when you can do that, you can begin to prioritize. Otherwise, parents are stressed out as well by all the demands that are being put on them to be kind of like perfect parents through this.
Mm-hmm. Let's get to one of the questions we have here. How do you recognize mental health issues in children? When should you get help and how?
I always say parents really have such a great read on their children. There's no one who knows their personality as well as that parent. And so when the parent tells you that something seems different or off, I think those of us as the professionals listen to that, and then it's our job to figure out why that is. So some parents will notice things like in the younger child, regression in developmental milestones. The child suddenly who's been toilet trained now is starting to have accidents. Or the child who's presenting with stomach aches or headaches or other somatic complaints are often a first sign that there's something going on when there's no medical basis for it, that there may be an emotional issue. I think when you look at where children spend the majority of their day in school, and when you begin to see changes in their success there, that they're not either keeping up with work or their grades are slipping or a change in friends, those are the barometer. Those are the things that you kind of keep your finger on the pulse. When you look at, are they isolating more? Are they withdrawing? And you always have to put it in the context of like when you get up into the teen years of, well, yeah, they are going to pull away from family a little bit and they're going to spend more time with their friends, but there's a feel to that that's different. And so when we begin to alienate and we begin to change our circle of friends and we see regression in behaviors or a change in behaviors that are out of character, I think those are all your warning signs that something may be up. The other is that families know their families pretty well, and you know what's in the family line. And so genetically, if somebody in the family has had suicide, or someone's had depression or anxiety, and it's gone into multiple family members, then you pay attention to, is this the beginning of a disorder in the child? And you just kind of like pull that factor in as well. Can you think of anything else, Dr. Ross, that?
No, I think you hit most of them, especially with younger kids. The only thing I can think of, I guess teens too, is sometimes just basic like changes in appetite, changes in sleep. Like just pay attention to their day-to-day. If they normally are a pretty good sleeper and now their sleep-wake cycle is totally messed up, or they're a good eater and now they're kind of nitpicking at what they're eating at different meals. Sometimes kids are better at showing us behaviorally than they are telling us emotionally what's going on. So like Dr. Ricardi said, gut instinct of parents is often the number one best way to recognize that something might be off and it's time to seek professional opinion. But even if a kid is saying, I'm totally fine, if you have that gut instinct and you're noticing some changes in their behavior, that's probably a good time to seek out an opinion.
And how do you reach out? What's kind of the first step? Do you recommend pediatrician for resources? How do you know where to start, whether you're heading towards psychiatry or psychology for help?
So I think it's a typical psychology answer. It depends. If you are really concerned and you're seeing anything like self-harm, or there are really major changes in their behavior that prompt safety concerns, then you need to take your child to the ED for an evaluation if you're genuinely concerned risk to themselves or others. If it's more their mood just seems off and I can't really figure out why, and you have a pediatrician appointment coming up, sure, absolutely talk to them. But if you're getting the sense that issues with their emotional functioning or mood are interfering with their ability to do the things they like to do, it's impacting their day-to-day life in a negative way that's noticeable, then it's probably time to seek out a psychologist if you want someone who can talk through the problems and provide evidence-based therapy through cognitive changes, behavioral changes, and emotional changes. Or if you think, my child really needs a medication, they're so anxious that they can't even talk to someone about what's going on, then pursuing psychiatry can be helpful as well. But the best team are teams where mental health, psychology, and psychiatry work together and work collaboratively with each other. And you can find these resources. I mean, flip your insurance card over. Insurances have a behavioral health line that you can call and see who's accepting new patients, what areas of specialty are within the practice. And if you are a Phoenix Children's family, all PCH psychology or PCH psychiatry, and you can run the case down with one of our administrative assistants, and they can guide you like, I think this sounds more like psychiatry, or yep, this sounds appropriate. Let's see when we can get you in here.
I do think the pediatricians are crucial and key and a valuable resource, because if you think about it, they've been following probably this child for a long period of time and know the family and know siblings. And so they also know community referrals and resources. And so I think using them, using case managers through the insurance plans are often good ways of beginning to at least have that initial assessment. There will be some kids who obviously will end up in the emergency room, which kind of raises it to a new level, and we get involved that way. But I find a lot of families who come down to us have come from other resources that have been tried and then don't work, whether it's coming from pediatrics or it's coming from a therapist or a community psychiatrist. So I think there's a variety of ways, and it just depends on the severity of symptoms.
This other question, are there any resources available to help families who have PTSD associated with the treatment of their child or sibling?
So no, you're not alone. That's one of my major research interests, is because we are seeing this so prevalently throughout the hospital. Sometimes it's not that someone meets, a family member meets diagnosis criteria for PTSD, but they are saying like, I'm having flashbacks, or I feel jumpier, I don't want to come back to the hospital. If there are symptoms of PTSD that are interfering with your daily life, that's one of the diagnoses. We have some excellent evidence-based interventions to help with that, and I would encourage you to seek out professional mental health support. After about 6 months, if PTSD symptoms are still present, it's unlikely that they're going to get significantly better unless there's no chance that the trauma will happen again. And for most people, the schemas and the fear are so embedded in the neural networks by then that the symptoms of PTSD will still be prevalent. So the best resource I think you can do, there are apps available for like deep breathing and mindfulness. There are some cognitive behavioral therapies, support groups in the community, and anyone who's listening, if you email hosts or organizers, I'm happy to speak to anyone directly and email you some resources. But if symptoms are interfering, then that is the time to seek out professional assistance. PTSD symptoms are unlikely to go away on their own.
Mm-hmm. And even in the family, I think it's important to recognize, like bone marrow, when you talked about bone marrow transplants, I mean, we may see up to 40% of parents developing PTSD. And so when you think about the family unit, it's not just about getting resources for the child, but maybe helping the parents or siblings as well.
Yes, absolutely.
We have another question here. So what is the most prevalent issue that you see in children at PCH, and how are you treating that issue? Is it from trauma and PTSD, or is it other issues? Also, do you have another patient story maybe that resonates with you?
I think it might be different for psychology and psychiatry, our responses to this question. Also, I am pretty much 100% inpatient, so I can't speak to what the presenting concerns are as well that our outpatient folks here are working with. The most common issue that we get consulted for inpatient is difficulty adjusting to diagnosis hospitalization. So a family member or the treatment team just says, you know what, since they've been admitted, they just don't seem themselves. And 9 times out of 10, we'll go assess and say, normal, like this is not where a kid's supposed to be on a Saturday or a Friday afternoon, so normal that they're feeling more down. The most common consequences for that 10% where we walk in and say, no, this may be something larger, tends to be either anxiety or depression. For anxiety, we can do relaxation strategies. We have some cognitive behavioral techniques. There's an intervention called acceptance and commitment therapy, or ACT, that really relies on looking at a patient's values and how do they want to present themselves to the world in line with those values. That has been pretty effective in working with anxiety symptoms. Depressive symptoms, depending on severity, we have different interventions like dialectical behavior therapy that we can use, but for instances of significant anxiety or depression, we will always loop psychiatry in because, again, we would need both.
And for me, I think one of the most striking and challenging issues for us is the trend in the last 10 years of suicide attempts and completed suicides in youth in this country. And when we look at children's, we've seen that same spike over the last 10 years of visits to the emergency room of kids even under 10. We'll even see sometimes preschoolers coming in who are expressing suicidal thoughts or behaviors. And so for us, it's become a national but also local crisis for us to identify those kids before they come to the emergency room for a suicide attempt. There's nothing more heartbreaking than, I think, when we see successful suicides and you have to talk to families about that and to watch them withdraw somebody from life support as they donate organs. I mean, that is just something that people should not have to go through. And so there's been an initiative at the hospital that we begin to screen high-risk patients for suicidal ideation and be able to get them referred to appropriate resources before we see them in the emergency room. And so we're beginning to do more global, pervasive suicidal screening in the outpatient psych clinics, but also like in adolescent medicine, in the homeless area of the medical. It's going to be now being done on the medical floors, in the ED, obviously in the inpatient psych. And we're surprised at some visits when we see somebody coming in for like a chronic ear infection, that during the course of that visit, that the child has been having suicidal thoughts that had never been kind of voiced to anybody, and we're able to get them triaged into appropriate care.
Dr. Ross, Dr. Ricardi, thank you guys both so much. We had some really great questions. We so appreciate it. I'm going to turn things over to Kelly right now because we're running out of time.
Oh no. We'll come back.
Thank you so much, Rachel, for moderating our program. Dr. Ricardi and Dr. Ross, thank you so much for joining us to share your expertise on mental health and management of pediatric patients with multiple diagnoses. To all of our guests, thank you for joining us as well. If you have any feedback that you'd like to share about the webinar, a post-webinar email will be sent to you. Please give us your comments. We love to hear them. And also you can reach out to your PCH representative who invited you today. Have a great afternoon, a great Memorial Day weekend. Thank you for all you do for PCH, and stay safe and stay healthy. Thank you.
Thanks, everyone. Be safe.